Welcome to the third part of vasculitis. In the first two parts, we have seen into the various types of classification, and we have also seen the varieties of large vessel arthritis. Also, we have seen the medium sized vessels arthritis. And continuing the types of vasculitis, now we are going to discuss about Kawasaki disease. Kawasaki disease is also referred as mucocutaneous lymph node syndrome. Although its etiology is unknown, but it's associated with a febrile disease that is associated with fewer paroxysms. Mostly it affects children and infants which are below the age of 5 years. Now, what is the clinical presentation? Although its onset is abrupt, but it's associated with high fever ranging from a week to 2 weeks. Also, we have painful cervical lymphadenopathy, bilateral conjunctival congestion, dryness, redness, and fissuring of lips, strawberry tongue. So, if you can relate this picture with the congestion picture created by belladonna, where we see strawberry tongue is an exemplary finding in cases calling for belladonna. Exanthema of trunk, redness of palms and soles with teeth fermentation, carditis with heart murmurs and ECG changes can also be seen. Coronary artery disease associated with dilatation and aneurysm, abdominal pain, vomiting, diarrhea, and arthritis are the clinical manifestation of Kawasaki disease. So this is how the picture looks like. As you can see, truncal exanthema and strawberry tongue can also be seen in this picture. And palms and soles get red. You have this picture of Kawasaki disease. Now, continuing this series, now we have ended up with the medium size uh, vessels diseases. So now we'll start with the small vessel disease. So this was a classification chart. Now in this, we have ANC, that is anti-neutrophilic cytoplasmic antibody related associated diseases, where the very first one, EGPA, eosinophilic granulomatosis with polyangiitis, is known as Church-Strauss syndrome. We'll start with this. Church-Strauss syndrome, where we find hypereosinophilia, asthma and allergic rhinitis, pulmonary infiltration, cutaneous eruptions, pericarditis, cardiomyopathy, and myocardial infarction. Polymorph polynucleus PMNs is found in 70% of cases, and renal diseases, which are generally mild in nature, can be seen. In connection to laboratory findings, 70% of patients will have anti-myeloperoxidase antibodies, which are in association with the anti-neutrophilic cytoplasmic antibodies. Eosinophilia, anemia, raised TSR, and biopsy might be done to confer or to confirm its presence of the disease. Now continuing with the second type, that is Wegener's granulomatosis. Wegener's granulomatosis, it's a relatively rare disease, and it is found with a triad. It's a necrotizing granulomatosis where vasculitis of upper and lower airway is quite common. So what we find here is that the respiratory tract gets affected. Also, we see that systemic vasculitis is present and focal necrotizing disease, renal necrosis can be seen. The spectrum and severity of the disease ranges from the severity of disease from limited disease involving only one side to severe generalized multi-organ vasculitis may be seen. The male-female ratio stands out to be around 3:2. So it's more common in males as compared to the female, and mainly white and average age of people around 40 years of age are affected. Clinical presentation is it's affecting the upper airway arteries. So what we find sinusitis, nasal discharge, ulceration, septal perforation, and cartilage destruction. There is saddle nose deformity is found. Otitis media uh, is also a finding. So, tracheal inflammation, subglottic stenosis may be seen. Lung involvement may be associated with cough, dyspnea, hemoptysis, massive pulmonary hemorrhage, life-threatening. It's because it will impair the respiratory exchange and leading to collapse of the respiratory system. Proteinuria and hematuria if the kidney is involved, chronic renal failure, end-stage renal failure might be seen. This is the picture how it looks like. Various organs getting involved. You can see have a closer look how it looks like. Another clinical presentation of bilateral fluffy infiltration into the pulmonary cavity gives you an idea of how this disease develops. Laboratory diagnosis, normochromic normocytic anemia might be seen, leukocytosis and thrombocytosis is associated. Leukocytosis is elevation in the number of WBC, whereas thrombocytosis is elevation in the number of platelets. Elevated erythrocyte sedimentation rate. Fingers it's also associated with the presence of these antibodies and also anti-proteinase 3 antibodies. Titer associated with disease activity and biopsy specimen show diagnostic granulomas. Now, considering the classification, and we are left with the last category, that is immune complex vasculitis, not showing purpura. IgA vasculitis is an immune or the immunoglobulin associated vasculitis. It's the most common hypersensitivity vasculitis of childhood and young adult, preceded by upper respiratory tract infection, but the etiology is unknown. Both males and female would be affected, and the age of onset is quite early. Usually, this is a self-limiting disease in most of the patient. The classical triad is palpable purpura with a normal platelet count, colicky abdomen and arthritis with or without fever. You can see the petechial hemorrhage on the skin in the picture shown with this slide. Purpura appears first on the lower extremities, dependent area and buttocks. Arthritis is transient and usually involves knees and ankle. Hemoptysis is up to one-third of patients. 50% have occult gastrointestinal bleeding. 10 to 50% has renal involvement. And may also be associated by microscopic hematuria and glomerulonephritis. Diagnosis is made on the clinical ground with skin biopsy, that be a confirmative test. Laboratory results are variable for ESR and immune complex like IgA. Now we have Behcet syndrome, which is usually associated with oral ulcers and genital ulcers. Diagnostic criteria for Behcet is you can see the clinical features and recurrent oral ulceration and observed by physician or patient that recurred more than 3 times a year. Plus, two of the following criteria are essential: recurrent genital ulceration, ocular lesions, skin lesions, and positive pathology test. How do you perform this? It is performed with a less than 21 gauge needle under sterile condition and observed by physician at 48 hours. Skin lesions will include erythema nodosum and pseudofolliculitis, a papulopustular lesion and acne from nodules. Anterior uveitis, posterior uveitis, or cell in vitreous and slit lamp examination and renal vasculitis observed by ophthalmologist. So you can see here the erythema nodosum and also the positive pathology test where uh, an cage needle was inserted and observation was done for ranging the spread in that lesion. That is all with the third part of vasculitis. This was the end. We do have some cases to follow up these cases and to guess the disease of the vasculitis. Follow the fourth part of vasculitis.